despite lack of SIRS. But it was a description in a journal in 2015, about 12% of the patients in an Australia collection did not even have SIRS, so there was a lot of dissatisfaction. Not only was it too sensitive, it wasn't even specific. And there's a lot of stuff that goes on with sepsis, like altermentation, oliguria, that are not included with SIRS, and yet the presentation is multifaceted and not captured by SIRS criteria. So big data, a big database, went into the past and teased out a new definition, which was an attempt to be more specific. And in fact, they defined sepsis as a life-threatening organ dysfunction due to a dysregulated host response, and it was included organ dysfunction as part of that. And as a screening tool, they came up with something called the Quick Sequential Organ Failure Assessment, QSOFA, where you need to have 2 of the 3. This included a low Glasgow Coma score, tachypnea, just like when SIRS, tachypnea, or hypotension, 2 out of 3. And in terms of the intensive care unit, a new definition of sepsis included an increase in the old-fashioned classic ICU SOFA score with the various organ dysfunctions you see here. Septic shock was defined as a subset where you had profound hypoperfusion and hypotension despite volume resuscitation. So persistence of hypotension requiring vasopressors was inherent to the definition of septic shock, often including a lactate of at least 2. And in this big data analysis, the mortality was quite significant, in excess of 40%. So when we look at the old definition compared to, which is called sepsis 2, and compared to sepsis 3, we really see a shift here, right? Because in the old definition, you didn't need to have organ dysfunction. In the new definition, you do. So there's really no word called severe sepsis, the new definition. Everyone we used to call severe sepsis is the new definition of sepsis, you see? So these patients are sicker. So it's more specific. Unfortunately, it's not as sensitive as I'll share with you in just a second. So when you look at the prognostic accuracy, with the new definition, you have more true positives. It is more specific. Unfortunately, there are false negatives. With the old definition, you had many, many more false positives. Again, trauma, pancreatitis, there's a lot of reasons to have SIRS that are not necessarily due to sepsis. So really what you're talking about here when you compare sepsis 2 to sepsis 3 is a trade-off. And what is the trade-off you wish to make? SIRS is sensitive but not specific. So the old definition is true that you're more likely to overdiagnose sepsis. With QSOFA and sepsis 3, you're unfortunately going to miss some patients who have sepsis. So what would you rather do? Would you rather miss some patients, knowing that we know about sepsis treatment and early intervention being important, or would you like to overtreat and then de-escalate? So it is true that the new definition with SOFA and QSOFA are not standalone definitions. So even though the new definition is more specific and truly based on data instead of expert opinion, which was the case in sepsis 2, you have the opportunity, though, to underdiagnose and undertreat. Now, why is that important? Well, here's one example. This is data from 6 years ago now in the New England Journal from New York State. And everyone's familiar with the sepsis bundle, which includes 30 cc volume resuscitation per kilo and stat antibiotics, blood cultures, and lactate. Of course, they're diagnostic, but the treatments are fluids and antibiotics. And in the ICUs in the state of New York that were more compliant had lower mortalities. What does that mean? That means you pay a price for delayed recognition. So I would argue it's probably better. So you can't do away with sepsis 2. It's probably better to overdiagnose and not miss anybody and then de-escalate antibiotics when you decide, oh, this was just pancreatitis or trauma, than it is to only use the new definition. So the new definition is nice based on data, but it didn't make the old definition go away. And I think most people would argue the new definition is incomplete in that regard. So sepsis 3 is defined from a large database in patients that were treated for sepsis using the old definition and uses QSOFA as a screening tool. There you see 2 out of 3, including Glasgow coma, tachypnea, and hypotension. But if you only treated patients identified by sepsis 3, you're going to miss some people and it will hurt them. So because early identification and treatment improves outcomes, most sepsis screening tools in emergency departments actually use the old definition. So that is my 5 minutes, and I'll be back later. Thank you.